Just sorry, Alan, I will say just few words in Italian language and then I will switch in English. Voglio dire ai partecipanti, intanto ho visto che ce ne sono almeno 28 già collegati, partiamo anche per rispetto nei confronti di Alan Sioe e voglio dire di mandare le domande su Key and Hey che voi vedete nella barra inferiore e non nelle chat perché altrimenti non vediamo le vostre domande. Se qualcuno ha voglia di scrivere in italiano perché si scoccia di scrivere in inglese, lo può fare, noi lo tradurremo seduta stante. C'è un gruppo che è pronto per fare questo. A questo punto cominciamo e ovviamente switch in inglese. Dear colleagues, dear friends, good evening. So we are going to start the third section of the webinar on management of the airways injuries in COVID patients, which was organized by the SIET Society, of which I have the privilege to be the president. As you know, today the focus will be on barotraumatic injuries in post-intubated COVID patients that will be discussed with an extraordinary experts panel. It is my pleasure to have with us two of my dear friends, Professor Alan Sioe from Glen Angle from Hong Kong Hospital and Professor Pierluigi Filosso from Torino University. Professor Enrico Ruffini sends his apologies for the absence due to some unexpected institutional commitment. Hopefully, he will join us before the end of this webinar for an additional contribution. However, I cannot start without giving my thanks to Giacomo Cusumano and Filippo Lococo, my co-chair for today's session. Both are active members of and counselors of this society for the excellent program. Thank you. Thank you, Professor Lococo. No less important, I want to give my thanks to my team and the irreplaceable Teresa Young-Hay, my assistant, who have always supported me. Also, my thanks go to our secretariat, specifically Francesca Cocchio of the Society, and to Simone Uberti for the management of a webinar platform, as well as my special gratitude to Medtronic, our valuable supporter. So after this due thanks, it is my honor to introduce the first speaker, Professor Filosso, who will illustrate some interesting cases happened during this pandemic in Italy and then in Torino. Please, Pierluigi.
I should share my screen with my presentation. Is it not?
Yep.
Doesn't work.
Sì.
Do you see my presentation?
Yes.
Sì.
Ah, okay. I wish to thank the Society first. I wish to thank my dear friend Franca for this very important, very huge, very kind invitation. I'm very happy, I'm very proud to be here today in this webinar. And I'm very, very happy also to share with you the Torino experience in primo-mediastinum management in COVID-19 positive patients. This is my disclosure for today. And I think that we should have a sort of preamble concerning what happens to the lung in the clinical scenario of COVID-19 infection. This virus mainly affects the respiratory system, as we always know, and elderly patient and those with comorbidities are at higher risk of death, which is usually caused by ARDS, which is the rapid progression of the disease from the infection to death of the patient, say. So looking at the chest imaging, there is very, very often a bilateral lung involvement with multifocal shadows or ground glass opacity, and with the possible also mixture with GGOs and lung consolidations. From the pathological point of view, I think that it's important, this issue, because the pathologists, especially from China, who, as we know, experience a very huge number of patients in December and January, all describe a diffuse alveolar damage with the formation of hyaline membrane, with the development of pulmonary edema, and the predominance of lymphocytes. Generally, frankly speaking, it's from the pathological point of view, and Alan will confirm this issue, greatly resembles the pathological feature of MERS, 2009-2007 MERS we had in the Middle East. Moving more in detail to the top of my topics, pneumomediastinum is defined as the entering of extraluminal gas into the mediastinum with the MacLean effect, which is a sort of three-step pathophysiological thing that is done through a blunt traumatic alveolar ruptures, the air dissection along the bronchovascular sheath, and the spread into the mediastinum. All the images I will show you are images I achieved in our hospital, and in which we had a large number of COVID positive patients, both in the normal wards as in intensive care and semi-intensive cares. So all the radiological images are of Torino, University of Torino Hospital experience. Why those patients are at high risk for pneumomediastinum? Because they are mechanically ventilated with very high positive pressure due to the extreme large damage of the lung. At the end of the ill, there is the impossibility to ventilate the patient due to the dramatic increase of lung tissue damages. Very often, pneumomediastinum is associated with pneumothorax, sometimes bilateral, with subcutaneous emphysema, COPD, and pneumotocele. These are some examples of what the association between COVID-19 pneumomediastinum and subcutaneous emphysema means. In such patients in which you can see the diffused subcutaneous emphysema, but also pneumothorax, unilateral or bilateral pneumothorax. Which are the causes of pneumomediastinum? I think that the upper airway inflammation and edema is one of the most important cause for the pneumomediastinum. We also have to remember that those patients have been usually rapid intubated for their severe hypoxemia and for the very often an emergent and intubation in emergency setting with the high risk of barotrauma. Sometimes we have a major proximal tracheal injury, but also the patient repositioning maneuvers like, for example, the proning the patient to optimize their ventilation is maybe the cause of a tracheal injury or pneumothorax or pneumomediastinum development. The treatment is different according to several experience. Some experience, not very numerous experience reported in the literature. very often, in the majority of cases, there is a conservative approach, especially when the patient moves from CPAP to mechanical ventilation. Sometimes, as we usually do in our hospital, we place a chest tube, especially when there is associated, when a pneumothorax is associated, or especially in case of ventilated patient. Sometimes some authors, like those coming from the Guy Hospital in London, suggest the use of bilateral chest drainage plus the placement of subcutaneous catheter to reduce the subcutaneous air. But I think that the key message is to recognize and treat the possible trachea injuries, as well as to rule out possible esophageal causes of pneumomediastinum. This is the case we operated two days ago. It's, as you can see, it's a COVID positive patient in which a very huge subcutaneous emphysema appeared with pneumomediastinum, as you can see, with bilateral pneumothorax, which was caused by the rupture of those group of bullae. And we performed a VATS procedure in the right side. This was the image in VATS of the pneumomediastinum, and this is the evidence of the damaged lung by the virus. And these were the bullae we resected through a very limited atypical resection of the apex of the lung. And this was the postoperative day one chest X-ray, which is the situation is very well controlled, as well as the subcutaneous emphysema. I think that the lack of physical examination may put at high risk those patients to be treated inappropriately. There is a very high risk of development of pneumomediastinum and pneumothorax in such patients, and therefore my suggestion, my message is that especially in ICU setting, a careful monitor of the patient is of paramount importance. Sometimes we also face with this situation, pneumothorax or more dangerous tension pneumothorax. Few cases have been reported in the literature. This is a case we observed in 1 month ago. It should be suspected when there is a immediate, rapid worsening of the clinical symptoms, respiratory clinical symptoms of the patient. A portable chest X-ray is very important, since through it we can have a very rapid bedside diagnosis and a rapid decompression, and the chest tube placement may ameliorate the situation in terms of respiratory symptoms of the patient. This is the reason why, once again, I think that we should remember to auscultate, to visit regularly the patient. Tension pneumothorax and pneumothorax in general are rare, no more than 1–2% in COVID-19 positive patient, according to this very recent publication I found in the literature. There is a very important issue whenever we decide to place a chest tube, because we do not forget that the lung is infected by the virus, and therefore we should minimize the exposure to the exposure risk to the staff during placement or removal of the chest tube. This is the reason why in this guideline paper I read and I summarize here for you, the tube thoracostomy for positive or suspected COVID-19 patient should be done by the most experienced surgeons, and with the fewest number of staff members required in the room. We are in fact doing this procedure in a very limited space with a very large number of actors, patients and healthcare personnel, with a high risk of airborne viral transmission, usually bedside, and we also need an adequate personal preventing equipment, and we have to try to prevent any possible virus aerosolization in the external environment. This is the reason why in our hospital we use this kind of device, which is a virus filter. Since if the chest tube doesn't have this, with air leak from the pleural space of the patient, virus may migrate from the lung into the suction canister, or whenever we place the chest tube or water seal in the room, with a very high risk of infection of the external environment. In Torino, our experience with the operated patient was focused on these two problems. Whenever we place the chest tubes or whenever we operate the patient, we observe very frequently persistent air leakage or incomplete lung re-expansion even after lung resection. So once again, the COVID-19 lung tissue is totally different from the normal parenchyma. This is the image. This is the case of a patient with a persistent pneumothorax even after the chest tube placement. And this is the dramatic situation of a patient who was operated for with a right upper lobectomy for mycetoma in COVID positive lungs, in which after a right upper lobectomy, a dramatic incomplete lung expansion occurred. So my conclusion are the following. Pneumothorax and pneumomediastinum and subcutaneous emphysema are possible complications of mechanical ventilation to which are done the COVID-19 positive patient. Those situations may worsen the patient respiratory situation, and this should be a very important caveat whenever we visit the patient and we see a rapid worsening of the respiratory conditions. An immediate pleural decompression usually improves the respiratory conditions. Whenever we face with possible pneumomediastinum, we have to recognize any possible cause, ruling out tracheal or esophageal injuries. And also, especially in ICU setting, a careful monitoring of the patient, I think it's of paramount importance. Don't forget to always visit and auscultate the patient. Don't focus only on the respiratory system monitor of your ventilator to judge if the patient is going well or not. So in conclusion, I cited here, this is a wish for all of us, since we have now in the phase 2, we are reopening all the, and we are coming back to our normal life. And so, citing Dante Alighieri in Inferno, quindi uscimo a rivedere le stelle. Thank you very much for your kind attention.
Eccellente, grazie, grazie mille. Thanks so much, and thanks for this pearl of Dante Alighieri. It is fantastic. Thank you.
Thank you, Franca. Thank you for the invitation.
And now it is my pleasure to introduce my good friend, Alan SIET. Please, Alan.
Okay, thank you so much. Okay, well, it's not easy following that fantastic experience sharing from Pierluigi. That was absolutely stunning, and it was all firsthand information. I'm afraid I don't have that much firsthand experience actually, as compared to what you have in Torino. In Hong Kong, we've had actually a relatively mild experience of COVID-19. But what I'll hope to share with you is a bit of our experience, what we do have, and certainly what's been published so far in the literature on barotrauma and especially spontaneous pneumothorax in COVID-19 patients. So my disclosures, just a few here. I think this top one here from Adila is probably relevant later on in this particular presentation. So anyway, my own experience with coronavirus infection actually goes back, of course, to 2003 with SARS, which in many, many ways is still very similar to what we have in 2020 with COVID-19. Now, back in SARS in 2003, Hong Kong, we had 22% of all the cases in the world were in Hong Kong. We had almost 1,800 cases and 300 deaths, making up 37% of all the deaths in the world in Hong Kong in 2003 with SARS. A mortality of 17% with SARS. It was actually a more lethal disease, it seems, than even COVID-19 nowadays. Now, compare that to 2020, because we learned our lesson in Hong Kong. COVID-19, we actually, till today, we only had 1,100 cases. We have fewer COVID-19 cases this year than we had with SARS in 2003. And look at deaths. We only had 4 deaths from COVID-19 this year. So certainly we've learned a lot of lessons from 2003. But what it does mean is that our personal experience with COVID-19, the severe cases of pneumomediastinum, barotrauma, pneumothorax, is actually less than we had with SARS. But anyway, let's share a little bit about what we learned with SARS back in 2003, because I think there's a bit of overlap. And certainly what we found in 2003 with SARS is that we did have quite a lot of patients who had SARS, who had coronavirus, ending up with spontaneous pneumothorax. Now, in 2 of the most badly affected hospitals in Hong Kong, out of a total of 356 SARS patients, there were 6 cases of spontaneous pneumothorax, which represented an incidence of 1.7%. But that 1.7% actually represented patients really on the more severe end of the scale, because of those 6 patients, 4 of them ended up in ICU and 2 of them actually died. And the picture of these patients with pneumothorax secondary to SARS looks very much like what you have today with COVID-19 patients who ended up with pneumothorax. We'll come to that in a minute. So just a closer look at our 6 patients back in 2003. You can see here that there was a good spread of ages. A lot of them were in the 30s and 40s. We had 1 patient who was 82. A lot of these patients, well, actually all of these patients were non-smokers, no previous lung disease. So the pneumothorax was definitely caused by the SARS itself. And of course, if you look at their LDH levels and neutrophil levels, they tended to be on the more severe end of the infection spectrum. A lot of these patients, actually, in fact, all of them were put on steroids. Back in 2003, we had no idea how to treat coronavirus. We ended up using steroids in a lot of these patients. And it could still be, we haven't proven it, but it could still be that steroids did have some contributing effect on these patients developing pneumothorax. So that's probably a lesson we can even apply today in 2020. In terms of patients who did have pneumothorax, only 2 of them actually ended up requiring mechanical ventilation after the development of the pneumothorax. Our patients, once they were found to have a pneumothorax, we just managed them actually with chest drainage. 2 patients refused to have their chest drains in. The 82-year-old patient, she just gave up, refused all treatment, and then she passed away. The other patients with chest drainage actually all managed to survive the pneumothorax, even the ones who were ventilated. And we didn't actually ended up operating on any of these patients. They all managed to survive on non-surgical management. So what we learned from SARS is that you do have a low rate of spontaneous pneumothorax, but these could be managed non-surgically, even in severe cases. Now, flash forward to 2020 and now with COVID-19, our experience, as I said, in Hong Kong with pneumothorax and COVID-19 patients is relatively limited. But let's just have a quick look at what the literature, the published literature so far has shown us. A lot of the The early pneumothorax cases, of course, came from China. You can see here, this is one of the earlier case reports from Wuhan. This is a case actually from January in Wuhan, a 38-year-old man. He first came in with the COVID-19 symptoms. You can see as the days went on, the pneumonitis got worse and worse. He eventually required non-invasive mechanical ventilation, and that's when he actually developed pneumomediastinum bulla formation and also a small left pneumothorax. This patient was actually managed relatively conservatively. He didn't even require a chest drain insertion, and he eventually actually did quite well, and his clinical course apparently resolved. So that was one case report. Another one, again from Wuhan. Again, this is a case from February, January to February in Wuhan. And again, another 38-year-old patient, again, came in with relatively severe symptoms. And as he went on, he didn't receive any mechanical ventilation, no positive pressure support, but he did develop a small left pneumothorax and bulla formation simply from the viral infection and pneumonitis itself. Again, this patient was treated conservatively, no chest drain was inserted, and this patient actually eventually fully recovered. So it was another case, spontaneous pneumothorax, conservatively managed. Here's another case from Hangzhou in China, a 62-year-old patient. And again, because I think at that point there were a few guidelines on how to manage these patients, he was given a healthy dose of methylprednisolone. And it's speculated whether or not this had any contributing factor to his developing a pneumothorax. And you can see here, he had a mild pneumomediastinum, bit of a pneumothorax. He was, again, managed conservatively, and he did well. You can see a pattern forming here. Most of these cases of spontaneous pneumothorax tend to be managed conservatively. Moving away from China, there are two cases from Istanbul. This one here was published in April, an 82-year-old female, similar to the one we had in SARS in 2003. She developed quite a nasty left-sided pneumothorax and also pneumomediastinum. This was treated with a chest drain, and actually, again, this patient actually managed to survive on chest drainage alone with conservative management, no surgery required. Another case from Turkey, a 24-year-old patient, again, this was treated, again, relatively conservatively, tube thoracostomy and just nasal oxygen therapy, and he did quite well. So all the way through here, and again, this is another case from Toronto, a more severe right-sided pneumothorax, again, treated conservatively. So the pattern right through here is that most of these cases do tend to resolve on relatively conservative management. Some cases, however, do actually present with more severe symptoms. And there's at least one case of a spontaneous tension pneumothorax. This was reported in London last month. And this patient actually had symptoms of coronavirus for 2 to 3 weeks before he actually had a sudden deterioration, sudden shortness of breath. And when he came in, you can see here a very large tension pneumothorax. He was treated, again, with just decompression and chest drainage. And the CT scan here on the right shows one of the later pictures subsequent to treatment with a bit of a bulla formation in there. But again, he managed to survive without surgical treatment. So all the way through here, I've been talking about non-surgical treatment, conservative management of chest drain, and this seems to work with the majority of cases of spontaneous pneumothorax. Has surgery been done? Well, we've just heard that in Torino and in certain parts of Italy, there have been cases where surgery has been required for persistent pneumothorax. This is a particular paper that was published online in the Annals in April from the Milan experience. They had 2 patients where they actually ended up performing bedside thoracoscopic bleb resection in COVID-19 patients. Both patients were operated on in the ICU, actually, and they both actually did very well. And surprisingly, both of them had their drains removed on postoperative day 2. So it is possible to treat air leak patients with surgery. But the difference between these 2 particular cases and all the cases I've shown you just now was that these were not spontaneous pneumothorax patients. Both of these patients actually were intubated, they were ventilated, and they developed pneumothorax secondary, presumably, to barotrauma. And surgery was done actually after they developed some air leakage. The combined experience with barotrauma-induced pneumothorax in COVID-19 patients around the world is still, a lot of it is still not published. A lot of the experience, especially in Italy, I gather, has still not been published. There are emerging case reports that are waiting to be published. This is one, it's unpublished data, so I won't elaborate too much, where the barotrauma resulting in severe pneumothorax and air leak seems to be out there. It could result in death. We don't know if it's the barotrauma and air leak resulting in death, or whether the barotrauma and pneumothorax is a reflection of the severity of the COVID-19 in these patients themselves. So I think we need more publication of case series around the world before we can actually reach any sort of conclusion. But what is clear, though, is that barotrauma in ventilated patients is something to pay attention to. Now, in Hong Kong, back in 2003 in SARS, in our particular hospital, of the patients who ended up ventilated, 26% actually ended up with barotrauma with pneumothorax. Most of these patients actually died. I think our experience back in 2003 was by the time you did have lungs bad enough that you could have barotrauma, the lungs are pretty severely damaged anyway, and no matter what you do, they had a poor prognosis. The early experience in Wuhan this year, this is one of the very early case series, seems to suggest that the barotrauma rate in ventilated patients with COVID-19 seems to be much lower than with SARS. However, these are just early results, and as I say, I think we do need the publication of results, especially from countries like Italy, from Spain, before we actually get a clearer picture on the actual scale of the problem in the current 2020 pandemic. Now, what can we do when we do have barotrauma? Well, the first thing to do is actually try and prevent it. And there are many guidelines out there on how to manage patients who are being ventilated with COVID-19. I think guidelines such as these, I think, are common knowledge to most hospitals around the world nowadays. So these are from the Society of Critical Care Medicine in the United States and the European Society of Intensive Care Medicine. And I think we all agree nowadays that where mechanical ventilation is required, a low tidal volume is recommended. It also recommends in severe cases that you should use PEEP. In fact, higher PEEP strategy is recommended. However, if this is required, there is that recommendation for very close monitoring, as Peter Luigi says, for barotrauma. These recommendations are echoed by the WHO in their latest interim guidelines. Again, a low tidal volume of ventilation and the use of higher end PEEP in these patients, with the caveat that patients need to be closely monitored for these harmful, i.e. barotrauma events that could occur in these COVID-19 patients. Now, what happens if you do end up with barotrauma and you do end up with pneumothorax and air leak? Well, you probably, in some cases, you need to intervene, either by putting in a chest drain or in some cases, as you saw, perhaps with surgery. Now, again, what we've learned from 2003 with SARS is that healthcare workers are at risk when managing these patients, specifically from aerosol generation. And we all recognize that now, that in any ventilated patients with the coronavirus, this risk is considerable. And back then we were already using things like AirMate power hoods and barrier man. And just in case you don't know what it is, I'm pretty sure you all do, this is what it looks like. Here on the left is me operating normally, and these two pictures in the middle are patients with standard precautions during a pandemic with full gowning and even hoods, double gloving, etc., etc. But if you have suspected or confirmed cases of COVID-19, then this is where the full barrier man comes in, a full airtight, full body suit with hood and an AirMate, a powered ventilation supply, air supply through the hood for breathing. And this is how we used to operate on all our patients in 2003. So far in 2020 in Hong Kong, thankfully, we haven't really resulted to this much in our patients this year. Of course, if you do decide to intervene in these patients and you do decide to operate on these patients, there are several areas where the staff and people around the patient are especially at risk. First is intubation. In Hong Kong, this is not from Hong Kong, these pictures, but we do the same thing. It's always intubation within the plastic bag and extubation within a plastic bag to reduce the risk. There are various guidelines on the anesthetic management of these patients. I won't go into all this in detail, but there are certain things like intubation, suction, bronchoscopy, which are high-risk procedures, possibly generating aerosols. The other source of risk when you intervene and manage these patients, of course, is when we actually do the surgery itself. And there's controversy over what surgical approach you should have for these patients if you're going to do bulectomy for them. Is it open surgery, traditional VATS, or even newer forms of VATS like portal VATS? Now, the controversy is especially pronounced, I think, amongst general surgeons. And a lot of the guidelines we see around the world are coming from general surgery. For example, in the UK, the United Royal Colleges of Surgery in the UK actually issued these guidelines back in April. And they specifically say that laparoscopy is considered to carry some risk of aerosol type formation. And that's probably because they always use CO2 insufflation in laparoscopy. And in fact, in the UK, a lot of our UK general surgery colleagues are now considering that laparoscopy shouldn't be done so much. And this is carried on even to some of our thoracic surgery colleagues. Some of them are a bit hesitant to use VATS. On the other hand, though, if again, sticking with the general surgeons, other surgical guidelines from general surgery actually says we should be using minimally invasive surgery, because if you use ports and you keep them as small as possible, then technically during the surgery, you're not allowing so much aerosols to escape into the general operating theater environment. So technically, maybe that should be safer. All you have to do, of course, is to keep your CO2 insufflation pressures low. In VATS, of course, we don't usually have this problem, so we should be safer. What you do have to be careful of course, if you do operate in these patients, is these electrosurgery devices. So that's diathermy, ultrasonic devices, et cetera, all of these potentially causes aerosols. So that's something to bear in mind. What we have done in Asia with the Asian Society of Cardiovascular and Thoracic Surgery, we're issuing a consensus statement, which should be out this coming week, recommending Asian surgeons on how to do thoracic cancer surgery during the COVID-19 pandemic. And I think what we decided on the consensus was that the choice of surgical approach, open or VATS, shouldn't actually make that much of a difference. We don't have enough evidence to say for or against. However, amongst those of us who actually are in favor of VATS, what we do say is that if you do perform VATS, then you're shortening the time the patient stays in hospital in a COVID-19 environment post-operatively. So you're potentially able to discharge patients out of danger as soon as possible. The other thing that we recommend is that we should discharge patients home, hopefully without a chest strain, because if they carry a chest strain out into the environment and they have COVID-19, then they are potentially a spreader in the environment. So we should keep these patients in hospital post-operatively. Now, this brings us on to our last topic, is the chest drainage issue. Now, we all recognize that when we have air leaks and you're bubbling through these traditional water seals, there is always that risk of creating aerosols and droplets. And with these traditional bottles, you see the outlet vent here is exposed directly into the atmosphere. And that causes a potential of these aerosols potentially containing virus-laden fomites into the ward environment, and that is dangerous for other patients and for staff. Now, have we any evidence for that? And actually there isn't. A lot of us, I think we agree that there is a potential risk, but there's not much evidence. This is a little article from our friends in London, actually posted on CTSnet, where they actually cited an example of they had a patient with a prolonged air leak who was later found to be positive for SARS, to COVID-19. And actually, subsequent to that patient being discharged, a number of patients on that surgical ward tested positive for COVID-19. Now, this isn't evidence, so they didn't claim that that patient directly contributed to the other patients getting COVID-19, but it's something to think about and worry about. I think we'll need more evidence there. But in the meantime, we do need to think about how we're going to manage our chest drains. So I think Pier Luigi already briefly mentioned this paper. So I'm just going to go through this just again. It's an excellent paper. You should have a look at this from the American Association for the Surgery of Trauma. If you have a patient with a chest drain, these are some very helpful tips. Tip number one, in that water seal, if you're using a water seal, put some dilute bleach into that water seal. Very effective at destroying the virus. So that's a very useful tip. If you are going to put a patient on chest drain, connect them to a wall suction, and you convert this into a closed system. More importantly, when you connect it to wall suction, put a viral filter on. And again, this is a much safer way of doing chest drainage. If you're not going to use a suction, if you're going to leave it on just a water seal open atmosphere, again, it's possible to put in a viral filter. And here's another tip I like a lot. Use cable ties, simple cable ties to secure all the connections. This not only prevents any leakage out here, but it also prevents inadvertent disconnection, which can put patients and staff at risk. So these are very, very useful and simple guides. Now, the thing about these viral filters is I don't know how available they are. I mean, certainly here in Hong Kong and most parts of Asia, we don't actually have many of these viral filters. So is there an alternative? Well, the alternative is potentially these digital chest drainage systems. These digital chest drainage systems tend to have a filter built into them. It's not a viral filter, it's a bacterial filter, but it's still better than nothing. Now, people will say, well, viruses are much smaller than bacteria. Even the fomites containing the virus is much smaller. How useful is the bacterial filter going to be? Well, we don't have much direct evidence for that, but what we can show is here's a paper from my colleagues, my previous colleagues in the University of Hong Kong, and this is looking at the use of face masks, normal surgical face masks, which are essentially the same filtration levels as a bacterial filter. And what we've shown is that if you use these for source control in the context of coronavirus, you can significantly reduce source spreading of both droplets and aerosols, even with simple surgical face masks. So if that applies to just exhaled breath, then you can imagine if you use it on chest drain, it's going to have a little bit of an effect, better than nothing if you don't have a viral filter. So the last word goes to the British Thoracic Society, and these are their final recommendations published a few weeks ago. For pneumothorax patients, they recognize that this is rare. If you do have patients with spontaneous pneumothorax, they do say that if patients are symptomatic, you need to put in a chest drain. Ideally, these chest drains should be an integrated device with closed systems to prevent spreading of the droplets and particles. If there's a large air leak, then certainly these patients should be admitted rather than being let out into the community where they can spread to other patients. If you do need a chest drain put in, then certainly, as we said just now, make sure it's a closed system if possible with low suction. Insert a viral filter if that's available. And if you're not, then an alternative method is to use these digital chest drains with a bacterial filter, which is better than nothing. So in conclusion, pneumothorax in COVID-19 patients, it's still a relatively rare thing. I think because we have so many COVID-19 patients today, you see quite a few of these cases, but overall it's relatively rare. I think overall, our experience both with SARS and with COVID-19 is that so far, at least in the literature, we see a lot of them in the spontaneous pneumothorax. That's been reported more than barotrauma, but I think as more reports come from around the world, we're probably going to see actually barotrauma is going to be more important than spontaneous pneumothorax in COVID-19 patients. The majority of these patients in our experience can be managed non-surgically, relatively conservatively with chest drainage alone, although in some cases you do need to intervene. And when you do, it's always the usual same thing. Beware of droplets and aerosols. If you're putting in a chest drain, always identify as a potential source of spread. And there are some simple measures, as you said just now, to prevent leakage. So thanks very much for listening to me. Thanks so much.
Thanks a lot.
Okay.
Thank you, Alan. I would ask my co-chair to manage the questions that I see are already present in the. Maybe you have to switch between the chat and the Q&A. Unfortunately, someone sent the question in the chat. Please, Filippo.
Hello, everybody. First of all, let me thank the president of our society, Franca, that is not only a president, she's a leader. And so thanks, Franca, for this great opportunity to co-moderate with you this seminar. And also, I'd like to congratulate with the panelists for their great presentation. First of all, for the practical indication and take-home messages from Professor Filosso, and also for this amazing comparison between SARS and COVID-19 performed by Professor CEO. And so we go straight to the questions of the audience. First of all, there is a question from Dottoressa Ceccarelli, who asked to Professor CEO if there is some similarities between SARS and COVID-19 pandemics. In your opinion, why COVID had lower number of cases in Hong Kong compared with SARS? What's your opinion about it?
That is a fantastic question. And I think Hong Kong is in a great position to answer that. And I think it really is. The answer is, back in 2003, SARS hit Hong Kong so bad. Nobody knew what was going on. We were at the forefront. We were at the epicenter of the entire world. So we had a lot of patients dying. We had a lot of colleagues. My own colleagues actually were in ICU and died. So we learned a lot of lessons. So as soon as this COVID-19 started outbreaking in China, even before the first case hit Hong Kong, everybody in Hong Kong was on alert. So this was back in January. So don't say that everybody was hiding the news. We all knew in Hong Kong what was going on. So even back in January, everybody already was putting on masks. There was social distancing, and we already expected the worst because we knew that anything that was going on in China is going to hit us. What we learned back in 2003 was that there were several things that were very, very effective. So I'm just going to very briefly share that with you. Number one is masks. Now, I think there are some parts of the world today where they still question the value of masks. Now, if you use masks for personal protection, yeah, it's not perfect, but it's better than nothing. But as a means of source control, where you're preventing yourself spreading to other people, it's very effective, especially if the majority of the population uses it. So we used that in 2003, we're using that in 2020 in January, and we managed to flatten the curve very effectively. The second thing, of course, is social distancing. We didn't call it that back in January, but as soon as it came out, everybody was just keeping a distance, staying apart from each other in the metro and elevators and things. The third thing, of course, is good hand hygiene. Now, one of the very important things that we learned in 2003 was that the index case, the first case that came to Hong Kong, was a super spreader, and he spread it in elevators. So in Hong Kong, everybody is in a tall building. We all use elevators. So immediately, everybody knew that the spread was at the buttons of the elevators. So ever since 2003, all the elevators in Hong Kong, we sterilized all the buttons. Everybody just didn't want to touch everything. Use a piece of tissue paper to press everything. And immediately in 2020, we started doing that, even before the first case came to Hong Kong. The fourth thing that we also were worried about is our own home environment, because in Hong Kong, we live very, very close together. And there were several outbreaks, I think, within close quarters. And so the drainage pipes, the sewage pipes, we made sure that the water seal and U-tubes were actually filled with water. We washed everything with bleach. Everybody in Hong Kong knows what 1 to 99 means. What 1 to 99 means is how much you dilute bleach to sterilize your home. So everybody started doing that. So these are very simple measures that we use to stop the spread of COVID-19 in 2020. Now, the good news for everybody around the world is because COVID-19 hit us all so hard that next time this virus comes along, we'll all know what to do. And I'm pretty sure next time we'll have a better experience.
Thank you. Another question comes from Dr. El Kayet, who asked, for Professor Filosco, some details more about indication for surgery in pneumothorax in COVID-19 patients. They ask the parameter, the indication for surgery. What's your opinion?
Filippo, I think that the most important thing is what Alan said before a few minutes ago in the take-home messages. Usually pneumothorax is a self-limiting event, and I think that it's rare. First, it's self-limiting event, especially in broad trauma patient. So I think that very, very, very frequently you don't need to operate patient with the pneumothorax. I mean, placing a chest tube is enough. That the patient I presented before was a very particular type of patient because he was a positive, COVID-19 positive with interstitial lung disease, with pneumomediastinum, with subcutaneous emphysema, with bilateral pneumothorax. The thoracic CT scan showed a larger group of bullae of emphysema at the apex, especially in the right side. This was the reason why we decided to operate him. We did an atypical resection via VATS, and I forgot to say, we did tal plurage to be sure that the event of another pneumothorax doesn't happen. But in our experience, chest tube placement, especially in ventilated patients, is enough to manage the spontaneous or barotraumatic pneumothorax. You can observe in many cases persistent air leak, which is self-limiting whenever you extube the patient, whenever you are able to manage the mechanical ventilation. Just to demonstrate the barotraumatic cause is the most important index to have the development of such cases of pneumothorax.
Yes. And just another detail, you said you perform talc, pleurodesis by talc.
Yes.
In other report, they perform just scarification, just mechanical pleurodesis, because probably they say there is maybe a confounding parameter, the inflammation by the talc with the inflammation of the pneumonia. So you say that the talc is safe in these cases anyway.
It was one patient only.
Yes.
I'm not, for us, it was effective since I show you the postoperative day 1 chest X-ray in which there was a complete expansion of the lung, no air leaks, another important clinical detail I have to show you. I don't know if tall pleurogy could worsen the situation, the parenchymal lung situation for such patient. I think that other cases may be necessary to document or not this situation.
Of course, we have no data anyway. There is a question for Professor Sioe. We say, what do you think that the large number of pneumothorax and pneumomediastinum are related to the pressure, or there is a role by the fragility of the lung due to the COVID-19 infection, which is more important in your opinion?
Well, that is a very good question. I think to answer this question, I think what we're recognizing so far, both with SARS and especially now with COVID-19, is that there are two distinct categories of pneumothorax we're looking at here. One is the spontaneous pneumothorax, and one is pneumothorax in patients who are under mechanical ventilation. Now, with the spontaneous pneumothorax, I think we can learn quite a lot, because as we've just seen just now with the cases I've shown you, so far of the cases reported, almost all of these patients had no underlying previous lung disease. Most of them are non-smokers with no special risk factors for pneumothorax. So it's easy to infer that it's almost certainly the COVID infection playing a key role in these patients developing pneumothorax. The other thing that we're noticing in the spontaneous pneumothorax patients is that the pneumothorax tends to occur after, on average, maybe 2 or 3 weeks. That seems to be the kind of key period. You get bad enough infections, some of them present late to doctors with COVID-19, and that's when they present with a bad pneumothorax. So certainly the fragility of the lung is important. Now, regards to the mechanical ventilation group patients, the barotrauma patients, I think the problem is so far that we don't have that many published case series. I think after this summer, hopefully a lot of our friends in Italy and around the world will be publishing these results, and we'll have a better understanding. of how big the problem is and what kind of parameters on the mechanical ventilation are contributing to the pneumothorax. At the moment, we don't know enough. Certainly, there is a subset of patients, certainly, with a very severe COVID-19. If they're bad enough to get put on a ventilator, your lungs are going to be bad. And certainly, those patients are going to be at very high risk for barotrauma. Absolutely. I think the other thing is we're thinking of is whether some of the treatments we're giving for patients with COVID-19 are also contributing to that. Steroids certainly seems to be involved, but again, we don't have enough published data yet to analyze that. So hopefully after the summer, we'll know a little bit more.
Yes. Another question for the audience from Dr. Wiesel from New York, I think for both. Do you notice a trend in timing of presentation of pneumomediastinum or pneumothorax relative to intubation? And I mean, there is some time correlation with change of position, because sometimes we have experience of pneumothorax after pronation, for example. We have some experience in literature of yourself. What do you think about it?
Yes, could I answer this question?
Yes, please.
Yes, with especially for pneumomediastinum, I think that it was done more frequently after CPAP administration. And whenever there is a worsening of the clinical situation of the patient, he's going to be ventilated. And therefore, this is the reason why in many cases, a conservative approach was done. So you have a ventilated patient, generally you don't need to place a chest tube in such a kind of in such a clinical scenario. Only if you have, and this was our experience, only if you have a pneumothorax. If there is the association between pneumomediastinum and pneumothorax, so we do the chest placement. Concerning the first part of the question proposed by the colleague from New York, I think that there was a trend in which you can observe a worsening of the radiological aspect of the lung damages. I mean, the amount of GGO or lung consolidations, this may improve the risk of developing pneumothorax or less frequently pneumomediastinum. I think that as soon as you worsen the clinical situation, the clinical scenario of the patient in terms of FiO2 or in general tidal volume, as soon as you have to improve your tidal volumes, as soon as you worsen the aspect of the oxygenation of the patient, as soon as you have the higher risk to develop complications. This is our experience in Torino. I don't know if Alan agree or.
Yeah, I have that was a fantastic answer. I have nothing more to add because again, we have so little experience compared to what you have.
But you, Alan, you mentioned in your presentation that you had a very huge experience with SARS. Did you observe the same situation with the SARS or not?
Yeah, with SARS, I think back then, again, if you were bad enough to require intubation, then of those 20-odd% that actually did end up with barotrauma and pneumothorax, they did tend to occur fairly quickly after the intubation event. But that's more a reflection of how bad the lung was. What we'll never know is that even if we didn't intubate these patients, whether or not they would have had pneumothorax anyway, the lungs are so bad. So I really don't have much more to add to that, I'm afraid. Yeah.
But I think, sorry, Filippo, I think that another key question, another key topic is to compare the outcome of such patient, I mean pneumomediastinum or pneumothorax patient, with comparing with the type of drugs used to control the virus infection. This should be another issue we could develop in our in the next future.
Mm.
Yeah, that is. And there is another question from the audience, and I give the correct space for the audience. They ask to Alan and Pierluigi, both from Dr. Feger, what pressure setting do you use on patients with persistent air leak? I mean, they see pressure during operation, I mean.
You mean the ventilation?
I mean, during operation, which kind of ventilation do you use? I mean, the TDAL, of course, they ask if minimum pressure, minimum ventilation, of course, to reduce the air leak is correct for you.
Well, we've had so little experience working on patients with confirmed infection and that we operate on. I think in general, though, in the ICU setting on ventilation, then we still go by the WHO guidelines. So we're talking about low tidal volumes with a certain amount of PEEP. We start off low and we titrate upwards. Again, just paying attention to the possibility of barotrauma, but I don't have anything more specific to say than that. I don't know, Pierluigi, do you have anything?
I think that this is a very, very fantastic question. And I agree with Alan that the lowest tidal volume you use, the better is for the patient. Yeah. We did some intervention in COVID-19 patient, positive patient. We did lobectomies. And we have two problems. We have to use a correct tidal volume first, not to improve the air leakage during or after the intervention, but you need a correct tidal volume not to improve the secretion or retention at the end of the intervention. This is the other big question we observed. I show you the patient in which there was a dramatic loss of lung expansion after the intervention. He underwent several bronchoscopic procedures to remove some secretion from the bronchi, and probably this was the effect of a very low tidal volume during the intervention, plus the presence of the hypersecretion condition of the patient itself.
Good. And we change a little bit the topic because ask, I mean, for Professor Sioe that have experience of digital drain, which is the effect of low suction on digital drainage devices after lobectomy, they say. Oh. I think lobectomy is, anyway, pulmonary resection. You apply suction in these cases anyway, or it depends?
Yeah. Well, that's fantastic. I love that question. It's one of my pet things. Well, normally, what I normally tend to do after lobectomy in non-COVID patients is I always give a little bit of suction. So we're talking about minus 15 to 20 centimeters of water, negative pressure on the first day. And I use that just to get the lung expanded fully. I think what a lot of our colleagues around the world find is that if you just use a water seal immediately after surgery, sometimes you do get a bit of a space with fluid collection at the bottom, and they say, oh, we need to put another drain to get it out. Actually, you don't. You just need the lung fully expanded. That gets rid of it, and it's done. The day after surgery, if there's no air leak, potentially you could just remove the chest drain. For the persistent air leaks, and I think this is more relevant to what our topic tonight, if you do have a persistent air leak, then yes, low suction on a digital chest drain device has so far, for me, worked very, very well. And so usually what I do is after emphysema surgery, for example, we start off with maybe minus 15. The next day we go down to gravity mode, so minus 8. And personally, if there's still an air leak, I just have it every day. So the next day I go to minus 4, and then I go to minus 2, and then I go to minus 1. And the great thing about most of these digital chest drain devices, as you know, is that they're self-regulating. So if there's an ongoing air leak, even if you set a very, very low suction, it's still, to maintain that low suction, it will still draw out all the air leak. So you don't actually have much of a lung collapse, even if you set a very low setting. So it's relatively safe. And when you have a very low intrapleural pressure there, the differential pressure between inside the lung and the interpleural space becomes much less. And anecdotally at least, and certainly in some of the published results so far around the world, it seems to reduce the duration of the air leak. I think we've published a couple of papers on that already. It seems to work. So it's something to try out. We haven't tried it out specifically on COVID-19 patients. So I don't know if there's anybody out there with COVID-19 patients. This is something that you could probably think about. Yeah.
And if I can, another question by myself to Pierluigi. You show us that there is, you use a small bore chest drain in your case, and I agree with you. Sometimes I've seen in some chest X-ray or chest CT scan, the other surgeon adopted a large bore, large drain, because they think we wait for a large air leak. So which is best, mini-invasive small bore chest drain, or think about a great air leak? We prefer large size. Which you advise us?
This is a very fantastic question, because it's a very, very important, very important issue. In our hospital, in our unit, in our department, we move our education from large bore to small bore catheter. Therefore, whenever we approach, in general, a pneumothorax, a spontaneous, recurrent, inpatient ventilated or not, we use a small bore catheter first. We use large bore whenever we have to face traumatic, hemopneumothorax, for example, after trauma or after thoracic traumas or polytraumas. But whenever you decide to use one instead of the other, it depends on first the type of lung parenchyma you can see at the chest X-ray, at the thoracic CT scan, sorry. Second, the amount of lung disease, I mean the infection, the COVID-19 infection. The largest infection you have in your lung, the highest is the risk of incomplete re-expansion and persistent air leak. Therefore, I believe that in such case, you have to use a middle or a large bore catheter. I believe 20, 24, 28 French catheter. So to conclude, it depends on several questions, several facts. It depends on the type of patient, the size of patient, the mechanical or ventilation or not, the type of lung injury you can observe at the chest imaging. However, our, how can I say, we prefer to use, first of all, a small bore.
I totally agree with everything you just said. The only thing I would add to that is that if you're faced with an acute situation, if a patient is symptomatic, just put in the drain that you're safe with.
Yes, it is.
Yeah, an acute patient, don't experiment.
I totally agree with you, Alan. That's no question about this.
Good.
May I? Sorry.
Hi.
Just a short question. You said, and I agree completely with, I fully agree with Alan and with Pierluigi for what you said. Just a short question. Do you prefer, just in case you have, for example, a complex patient, depends obviously if the patient has comorbidities or other, do you prefer one or two drainage?
Usually we use one drainage only.
In all cases?
There is only a situation in which we sometimes use two drainages. I mean in non-COVID patient, I mean yes. in lobectomy, in daily practice. Whenever do perform an upper bilobectomy, we usually place two chest drainages, one 24 anteriously, the other 28 posteriorly.
I just use one for everybody. The only times when I use two chest drains are for empyemas post-operatively with a relatively stiff lung. This may or may not apply to some of the COVID-19 patients who might have stiff lungs, but otherwise, yeah, usually just one drain is enough.
Yes.
Yes, also, yeah, I agree absolutely. And it is clear that with the empyema, maybe we can use larger size compared with the
Of course.
normal pneumothorax.
Of course.
It's clear. Another short question, may I? Sorry.
Yes.
Sorry. No, just I had a very no large experience for patients, for COVID patients. But I performed two procedures, one for mediastinum and one for pneumothorax. And I had some problems with the single lung ventilation. In other words, the anesthesiologists, they prefer don't use a selective tube. Did you have a similar situation, a similar experience? Both, for both speakers, please.
Alan, if you want to.
No, I don't have any experience of that.
Yes, I know.
Yeah, too few cases in Hong Kong, sorry.
Maybe during the SARS.
Yeah. No, actually, no, even back then, we didn't have much problems with that.
No?
It was, yeah, we were quite lucky, I think.
No, in our experience, there was only a situation in which the anesthesiologists don't want to use ventilation at all. It was a situation in which we operated the pleural empyema in a 44-year-old man, COVID positive, with a very large empyema, metapneumonic empyema, with severe cardiac comorbidity due to the COVID-19 itself. This was the reason why our anesthesiologists use only sedation, local anesthesia plus sedation. Otherwise, the other patient we operated on were completely intubated with the double lumen tube. Probably the question that made Franca was due to the difficulty of the anesthesiologist to perform the intubation in a COVID positive for the risk of aerosolization of the virus. May be the reason why he preferred to be very fast in intubating with a single lumen tube. Very easy to do the procedure. So I do my intubation very fast, very rapidly. So the patient is yours. I will take in apnea during some moment of the intervention. You're able to do your procedure, but I don't want it to be contaminated by the virus during the intubation procedure.
Filippo?
What I say, there are other questions, but the audience is, I think, satisfied by the answer of the presenters. I have it's just a curiosity, not a question. You say that in these cases, almost all the procedures are performed by experienced thoracic surgeons. So I asked you if I hope this pandemic is just finished, I hope. But if don't, what about the learning with the residents and so on? Because as you say, and I agree with you, that residency in this moment, residents are a little bit not involved in the chest drain in COVID patients and also in the surgical procedure. So what you can do both, so learning in the university, I mean, and at the same time perform our daily surgical activity. What do you say about it?
Learning, for me, learning curve doesn't exist in COVID-19 period, first. In Torino, we organized a COVID team, which was composed by 2 staff surgeons and 1 resident, very experienced resident, which were involved in, I was a member of this team, of course, which were involved in all the COVID procedures. So we put outside all the other components of our staff saying, please don't do this procedure because we are involved, we are on duty, we are on call, also for a medical legal problem. Because in our hospital, whenever you have a prolonged contact with a COVID positive patient, there is a clear procedure with control, with the swabs. And so our hospital preferred to limit the number of nasopharyngeal swabs to perform in no more than 2 or 3 healthcare personnel for procedure.
I think back in 2003 when we had SARS and we had quite a few chest drains we needed to put in, it was always led by an experienced thoracic surgeon, where sometimes we do bring in a resident so that they can observe and learn if it's feasible. It's important, though, I agree, that we should have an experienced person putting it in, because the last thing you want in a patient with a pneumothorax with COVID-19 is you have a badly placed chest drain. And if that causes any further lung trauma, then you're in a world of trouble. So yeah, that's my only advice.
There is another question from Professor Guglielmo Monaco, and asked if do you know cases of pneumomediastinum that required surgical therapy like cervicotomy or mediastinotomy. So impressive cases. Have you experience about them?
No, me no.
No.
No,
And
me
pneumopericardium that require decompression?
I have no experience on pneumopericardium.
Yeah, me neither.
I have experience of a pneumopericardium that require decompression.
Yes, actually. Yeah, actually, now come think of it, I did have a patient like that, pneumopericardium. It wasn't a SARS patient or a COVID-19 patient. I can't remember what it was for. We did actually ended up putting in an echo-guided, I think, small bore catheter for that, but it didn't really require any surgical therapy. Ultimately, it was just conservative.
Usually it's conservative. Yeah.
And you, what you did, Filippo, with your pneumopericardium patient?
A drain, just a drain.
Mm.
The problem was that the patient was in a prone supposition, and so we have to move, and it was not so a good day.
Was it causing a tamponade?
Actually, it was a young 56 man with a bilateral pneumothorax that always had chest drain, pneumomediastinum, and also pneumopericardium, probably by tracheal laceration, probably.
Wow.
But we don't know, because then unfortunately it was the death, and so we don't know.
Okay.
Any other question, Filippo?
There are no other questions from the audience, so I think the audience is satisfied. Okay,
thank you. So I would like to move to my conclusion. First of all, I hope, dear friends, that the whole webinar was interesting and stimulating for you. Just for your information, during the 3 sections have been collected specific statements for each topic. This was a very good idea of Filippo Lococo. And so each topic treated, which will undergo the Delphi process. Hopefully the results will be soon published. And so I would like to give my thanks. As you have seen, there is my thanks in Italian language, obviously, and in English. My special thanks to the speakers, to the participants, and obviously my co-chair. And also I would give my special thanks to the supporter, the Medtronic. Also my special thanks to the Medela company, which has shown an important interest on today's session, so that it has offered to publish a summary of this session. So for that, I would really like to give them my very special thanks. And again, I hope we will have soon again the chance to organize future interesting webinars, and maybe we can have some meeting in presence, I hope. And for that, I would stimulate you to send us proposals within the aim of this society. So thank you so much to all the participants. And with these words, I wish you a fantastic evening. Bye-bye. I send my kids to Alan and to Pier Filippo, and please, Pier Filippo, give my regards to Enrico.
Yes, mine too. Thank you,
Bye.
Franca. Thank you.
Bye.
Bye-bye.
Bye-bye.
Bye.
Thanks. Thank you, everybody.
The meeting.